Hello, everybody. Welcome to the tutorial session. That's what this is called. On infectious diseases. They've titled it, Be Prepared. Infectious diseases are here to stay. So I'm sure a lot of people stayed away because they were afraid. This is a scary subject. And in fact, I see the subhead for our conversation is threats. So appropriate in some ways, but also frankly, really wonderful that we have four very remarkable individuals here with us to talk about infectious diseases. There's no question this is a subject that's been on everyone's mind given what happened with the Ebola outbreak, but we also know that there's so many other considerations when thinking about infectious diseases and what they are. And again, no four people, I think, are better equipped to talk about this than the four people we have with us. So let me introduce them. Starting on your far right is STORN KABULUZI. He is the Director of Preventative Health Services for the Ministry of Health in Malawi. He's held that position for the last 4 years. Before this, he was the National Malaria Control Program Manager for that country, STORN KABULUZI. Next to him is NEERAJ MISTRY. He heads the Global Network for Neglected Tropical Diseases. He is a public health physician. He also founded something called the Global Business Coalition, which was focused on addressing health issues, health threats. Welcome to you, Dr. MISTRY. Next to him is Larry Brilliant. Dr. Brilliant is a senior advisor to Jeff Skoll and the Jeff Skoll Group. He's chairman of the Skoll Global Threats Fund, where he was its original president and CEO. And prior to that, he served as the chief philanthropy evangelist and the first executive director of Google.org, Dr. Larry Brilliant. And finally, next to me is Dr. Anthony Fauci, who is the director of the National Institute of Allergy and Infectious Diseases at the National Institutes of Health. He's also chief of the NIAID Laboratory of Immunoregulation. And as we know, he's one of the key advisors to the White House and HHS on AIDS and a number of other diseases. So again, this is a remarkable group. And we had a conversation among ourselves before we came over here. And I really wanted us to start by defining what we mean about infectious diseases, because I think some people have one idea, others may have a different one, and I think it's really important to clarify what we're talking about. So Tony Fauci, why don't you kick us off, kick it off with that.
Thank you, Judy. From its very simple standpoint, an infectious disease is a disease in which an agent infects an individual, and that is any of a number of microbes, viruses, bacteria, fungi, parasites. So that's the global umbrella definition of what an infectious disease is. When you look at infectious diseases, and which will come out in our discussion this afternoon, is that we tend to try to break it up for clarity into what we call established infectious diseases, that we can almost predict with some degree of accuracy from year to year what the morbidity and the mortality is. There's a great burden of infectious diseases out in the world. And you could take things like tuberculosis or malaria, now AIDS, even though AIDS was once a new emerging disease, it's now an established disease, and pretty much be able to predict diarrheal diseases, respiratory diseases. Then there's another category of diseases that we call emerging and re-emerging infectious diseases. And they're ones that are not prevalent in society, and they have different forms of a spectrum. A truly emerging disease is a brand new disease that we've never seen before. In 1981, we first recognized the first cases of what turned out to be HIV/AIDS. That is a new disease. We first recognized Ebola in 1976 as a new disease. MERS was first recognized in the Middle East as a new disease. Then there are other diseases that are what we call re-emerging. And re-emerging means they're not a new disease. They're in the textbooks, but they come at us in a different form, in a different way. Let me give you some examples. Two, for example. West Nile virus had been in Africa and in the Middle East forever. we can't even measure how long it's been there. But it came to the United States just about a decade or so ago, when it came in likely through a mosquito, a bird, or a person, but it now reemerged geographically in the United States. Extensively drug-resistant tuberculosis and drug-resistant malaria is a new form of that disease, very common ancient diseases, but they've reemerged. And then finally, there's a group of diseases that are deliberately emerging. For example, bioterror, anthrax attacks, and the things that we worry about. So those are the broad categories. And then, as we'll get into in our discussion, there are those that can be communicable from one person to another. Prototype example is flu, very easy to transmit. Measles, very easy to transmit. And then others, such as some of the parasitic diseases that you can get from the environment or from other animals, but you can't transmit it from one person to another. For example, schistosomiasis and other things like that. So when you think of infectious diseases, you got to put them into that broad category to understand what we'll be talking about over the next 45 minutes.
All right, I want to ask the other three of you, NEERAJ, Larry, STORN, how would you flesh out how we should think about how we define what infectious diseases are, and talk about difference between being infectious and being communicable?
Well,
So,
no, you go.
okay. So I'll sort of put it in two categories further to the delineations that Tony talked about. One is if we look at the diseases related to development, and this is a very traditional model in which we looked at it, development in terms of socioeconomic development. And the less developed countries, usually pestilence and famine, were the big diseases that cause morbidity and mortality, whereas with the more developed countries, they were diseases of affluence. So we had traditionally put it in that category. What we're finding now is, because we live in a much more globally connected world, that it's not infectious diseases that are relegated to those countries, but there's a shared vulnerability and threat. And we've seen this now with Ebola, and we're seeing schistosomiasis, a disease that you find in lakes and rivers in Africa, is now in places like Corsica, Italy, etc. So that was related to development. The other way of looking at it is the global killers, which we had the Spanish flu and the plague. These were pandemics, truly defined pandemics. They caused high mortality. Many millions of people died, and at the same time they had a huge geographic footprint, and that's what the definition was of a pandemic. And then there's other infectious diseases that cause this chronic morbidity, that is illness, and these are the types of diseases I work on, called neglected tropical diseases. And now we're starting to see global spread of them. They're not on everyone's radar because they're not huge killers, but they cause considerable morbidity. And the types of diseases we're talking about are dengue fever and chikungunya.
Mm-hmm. Which we've heard more about. STORN, what about, from your perspective in Malawi, what do you worry most about when people say infectious diseases?
Yes, thank you very much. As you said, that I'm responsible for disease prevention. My special interest is community health. And in community health, we put in place several activities that are there to make sure that we prevent, control infectious diseases. In Malawi, the major infectious disease, although the term we use are communicable and non-communicable diseases, I'm sure that during our discussions, we will discuss what is the difference between the two. But the way we tend to categorize them is between communicable and non-communicable. So the big three communicable diseases I could refer to in Malawi: malaria, HIV, TB. These are the big three. And then I'm happy that my colleague here mentioned neglected tropical diseases. We also have these neglected tropical diseases in Malawi. I think, as he said, that these are diseases of poverty, so to speak. The numbers we have for these diseases are very small, in a sense that sometimes we forget to put resources in order to control them. But what we need to do is to make sure that we put resources, we control them, we eliminate them, or even eradicate them. In Malawi, for example, the neglected tropical diseases we have, he mentioned schistosomiasis, which is bilharzia we have, lymphatic filariasis, We have onchocerciasis. We have leprosy. It's eliminated, but by definition of elimination, according to WHO, it's like you have to say that there's no more than a certain number of cases per given population. It doesn't mean that there are 0 cases. A lot of people get surprised when you tell them that in that part of Africa you still have got leprosy, although you are using the language that we have eliminated the disease. We also have got sleeping sickness, which is trypanosomiasis, which is there especially in the game reserves, where there are animals and the flies biting the animals and the people. The numbers are small in such a way that when we are getting drugs to the health facilities, normally you're talking of 1 or 2 bottles for a few individuals. So I'm happy that we have included neglected tropical diseases in addition to the big 3, which is malaria, TB, and HIV. Thank you.
Larry Brilliant, what would you add to that? And help us think about, should we be separating this, okay, here are the problems with infectious diseases in the developed world, and here are the problems in the developing world, or is that completely unhelpful to think about it that way?
I think every way of sorting these diseases is helpful for research or for policy planning or for response. I tend to look at them in 2 broad categories: pandemic potential organisms and diseases and those that are not. And in that way, you're looking at those things which are of lower probability but more highly consequential, and those that really form the vast burden of suffering that we have today. You can't think that a pandemic like H1N1 or swine flu or any of the pandemic organisms we're talking about are highly important today compared to the routine burden of disease. 350,000 people die every year of what we call ordinary seasonal flu. But if you're trying to think of what can bring humanity to our knees, what could end commerce, where there'd be no airplanes in the sky for 6 months and no ships carrying goods and services, you have to focus on a narrower set of problems. And we've had perhaps 30 novel emerging diseases that are pandemic potential emerged in the last 30 years. We could have an unlimited number from synthetic biology. We could have old friends come back now antibiotic resistant. But those are the things that I really worry about the most myself. But I don't dispute and never want to forget that it's the other infectious diseases that cause far more morbidity and mortality on an annual basis.
Just a quick definition. What do you mean by synthetic biology?
Well, the ability we have right now to do almost 3D printing of a virus from a genome that has been deconstructed and stored digitally is staggering. We can, without a lot of difficulty and with a lot of expense, we could replicate the 1917 influenza virus. We could create polio from, rudimentary materials. And it's not only that our scientists and our nation states can do that. We have had near misses in the recent past of people creating organisms that were deliberately introduced as an instrument of terror or war. And the world has changed as cybernetics and informatics and the internet coalesces with biology in so many wonderfully good ways, but we also have this dark side that we have to pay attention to.
Tony Fauci, people, in general, it's clear there have been so many advances made in medicine. We talk about the great, as Larry just referred to, the great advances in dealing with disease, getting rid of diseases that were killing many, many thousands of people. How much better off are we today than civilization was 1,000 years ago, 500 years ago? I mean, where are we? Because as we sit and we talk about these very real and worrisome threats, I mean, what sort of context should we look at it in?
The advances have been spectacular, Judy, because if you go back decades and decades, even into the last century, before people understood germ theory, before there were vaccines, infectious diseases, particularly among children, was a very, very important cause of morbidity and excess mortality, which was the major driver in bringing down life expectancy. So when you look at the curves of life expectancy then and now, that just answers your question. The life expectancy now is far, far greater in a far, far healthier way than it was back then. And one of the things that has contributed to that, it's a very complicated, because when you eliminate infectious diseases, then you start to see the impact of chronic diseases, which are another important problem and the subject of another whole discussion. But the ability to completely control a deadly killer, and in some cases eradicate, like smallpox eradication, elimination through most of the world of polio, with the hope that soon we're going to eradicate polio. Measles is eminently eliminatable and probably eradicatable. In this country, although there have been cases that we've seen spring up of measles because people were not vaccinated, we essentially eliminated measles years ago because of the vaccine program. So the advances that have been made, and that's the exciting thing about infectious diseases, but it's also the sobering thing. And the exciting thing is that you can really control it. I mean, you could decrease the incidence of heart disease, you could decrease the incidence of cancer, but you could not give it the kind of knockout punch that you can do with infectious diseases. So the short answer to your question is we've come an extraordinarily long way in controlling them.
We've come a long way, and yet we still have some very worrisome things. The Ebola outbreak, which a lot of conversation today and at this conference around that. NEERAJ, MISTRY, why are those kinds of things still happening? Why are we not able to put an end to all of these things since there have been so many technological advances?
So it was interesting for me to have trained and practiced in medicine and then did economics afterwards. And the mantra in economics is resource scarcity. But I think there's a different way of actually looking at it. We have resource abundance now. In the world today, we have more money, we have more infrastructure, we have technical capacity, etc. So everything that's actually required to respond to these epidemics, we have. And so it's not a shortage of the technology. Yes, we'll need new vaccines and we have to strengthen the pipeline, but we have a lot of tools that we can use now. For neglected tropical diseases, we don't pay a single cent for any of the drugs. They're all donated by the pharmaceutical industry. It's the biggest drug donation program out there. Yet we have challenges with access in very rural communities. So a lot of development has actually focused on looking at the capital cities. But where these diseases lurk are in the rural areas, and that's the areas that don't have infrastructure. Everything from clean water, running water, to sanitation, electrification, people don't wear shoes, which predispose them to getting these diseases. So that's one, that sort of environment. The second thing is that the response at that last mile always remains a challenge. It shows better when a capital city has a CAT scan and MRI than 20 community workers going out into very rural areas. And that's what actually, and Larry can speak to this, that's what actually changed and helped us get rid of diseases like smallpox, that last mile access. And so very much coming back to the question of resources, how do we allocate those resources that we do have to actually focus on that last mile access issue?
Can I jump in?
Yes.
So we're talking about some terrible things. People may be here really despondent. I want to give you something to make you feel really optimistic so that you can put everything else in context. How many of you were born before 1960? How many after 1960? Just about half. I guessed it right. So in 1960, 2 million people died of smallpox. In the 20th century, 500 million people died. It's 500 million, that's not a wordo, died of smallpox. We eradicated it. Took $120 million, took about 15 years, took a worldwide program. In India, it took 150,000 workers going door to door, calling on every single house in India once a month for 20 months. We made 2 billion house calls. We can do much better than that now. In polio, we had 4 million workers in India alone. We eradicated polio in India. It's been 3 years since the last case. We can do tremendous things together. In the middle of the Cold War, Soviet Union, United States were enemies on the battlefield, but they came together to work to eradicate this disease. We can do that. We can do it with any one of these outbreaks that occur and prevent them from becoming pandemics. if we put our attention on it and our will. So when you hear about all the bad things that are happening, know that we're capable of doing these great things like eradicate smallpox, polio, guinea worm. We could do it with measles if the public will was there. I don't want anybody to walk out of here thinking that, oh my God, we live in a world of microbes, it's just going to drown us.
So
Yeah.
just
And
the other
then-
side of the coin, and to complement what Larry said, is that you don't want to confuse an emergence of a microbe, either new or re-emerging, with an outbreak. There will always be, there always have been, there are now, and there will always be emerging infections. That's just the nature of our world and our interaction with the microbial world. Usually it jumps species from an animal. So 75% of all new infections are infections that are zoonotic, namely they're fundamentally in an animal, and they jump into the human. It's how we respond to it to prevent it from becoming an outbreak that's the issue. So we're never going to be sitting there saying, guess what? There are no more infectious diseases. That will never happen. That's the biggest pitch I give for people to go into an infectious disease fellowship.
Yes, can I
STORN,
just
yes.
add on this issue that yes, we have the strategies now, the tools to control the diseases, but what I want to add is that we need some means of getting those tools or strategies to the community. So what I can say is that in Malawi, for example, being one of the developing countries, I mentioned that I have special interest in community health. One of the challenges we have is a shortage of human resources. Sometimes we have like few community nurses. The community nurses we have, instead of being out in the community, they end up working in the hospital. Environmental health officers, there are very few. So what the government of Malawi did in order to solve this solution is to come up with a special cadre of community health workers. We call them health surveillance assistants. These
Health assistants?
health surveillance assistants.
Ah, okay.
Yes, they started, I think there was a mention of the time of the smallpox in the 1960s. At that time, community health workers were being employed on a temporary basis to deal with that issue. They were being called smallpox vaccinators. Then later in the 1970s, we had cholera outbreaks. Now, temporary community health workers were also employed to deal with the issues of cholera. For example, they were collecting data to send to the central office about where the cholera cases are, and also teaching the people on what to do in order not to get cholera. If they get cholera, just give the initial treatment to the people so that you save their lives. Then in the late 1990s, coming to 2000, the government of Malawi said, okay, let's employ the community health workers on a permanent basis as opposed to temporary. The idea was to fill that gap in the community. So we have employed them. They're employed by the Malawi government, and then they have basic education of all levels. Then we give them training for about 12 weeks. Then they get deployed to the community, to the hardest to reach areas. They have a manual that gives them a guide as to what tasks they can do there and what they are supposed to do and what they are supposed to do. Because of this strategy, it has been possible for us to make sure that there are community health workers in those areas. Their job is on disease surveillance, for example. They do report if there are occurrences of infectious diseases, disease prevention. They have to send messages to the people on health promotion. What should they do in order to get rid of the infectious disease? I think there was a mention of Ebola, for example. There is an element of cultural beliefs and what you normally do in your society. Sometimes, if people are not taught properly on how diseases are transmitted, they will do certain things when somebody has died, when somebody is ill, that will propagate that disease instead of preventing it. So that these community health workers now, what they do is to send the right messages to the people that in the presence of certain diseases, we need to change the way we behave so that we use the tools that are there to control the disease. So I just wanted to add that in addition to getting the tools in place, the strategies in place, we need to have means of getting those things to the community, whether you are in a developing country or a developed country. Otherwise, the job with the tools, if they are not there in the community, nothing can happen.
So clearly it's happening in some developing nations, but it's not happening everywhere, and Ebola has been the most dramatic example of that. What went wrong? I mean, I know there's a huge conversation around
Perfect
that,
storm.
but to connect with what we're here to talk about, infectious diseases, why did that end up happening?
I think it was a perfect storm. You could describe it in many ways, but if you look at the things that would allow a massive outbreak, the fact that there are a few people who get Ebola, and is generally an interaction with an animal, the fruit bat or butchering an animal that's infected. The linkage of that one or two people to go into hundreds and then thousands and then tens of thousands is really the lesion. And the lesion is that if you look at that geographic area, very little, if any, healthcare infrastructure to allow to do the major things that would prevent an outbreak from really spreading. And that is identify the case, isolate them, and do contact tracing, and isolate the contacts until, or at least follow them until you find out that they're not infected. In addition, you had countries that had porous borders. If you look at the map of West Africa, Guinea wraps itself around Sierra Leone and Liberia, and when the outbreak came in full blown in Guinea, you could look at right in that prefecture was right by the crossing of the borders of the countries. So there was porous borders back and forth. There was a complete distrust in authority, so that when the health authorities came, you have countries that have been racked by civil war, by oppression, by authority that was oppressive. All of those things, the healthcare infrastructure, there is one physician per 75,000 people in Liberia. And I often say, Judy, to the people when I talk in Washington, there are probably more doctors on K Street between 15th and 23rd than there were in Liberia. So all of those things make up the perfect storm. And then, as was just mentioned by STORN, some customs which are beautiful in and of themselves, the family's concern about taking care of their sick relatives, how you treat a body when a person dies with affection and love and caressing, all of that together propagated the outbreak. And it was just, as I say, it really was a perfect storm. It should not have happened. And it was, I think, the minimal infrastructure that was there was one of the major contributing factors to that.
Larry, brilliant, well, let me ask Larry first, and then NEERAJ. What were the lessons learned then from not everything went as it should have gone? What do we learn from that?
I think as humans and society, we have a problem dealing with issues that are of low or moderate probability and highly consequential, that occur infrequently. In the 20th century, there were 3 pandemics that killed over 1 million people each, but there were 3, and they weren't every year. We have an outbreak on the scale of Ebola infrequently enough that we don't, in the inter-epidemic period, maintain the vigilance, and we certainly don't maintain the global health governance system, which is deeply flawed. There is no cavalry coming. There are no white hats. There are no trained epidemiologists that are sitting in Geneva or in DC. We have a wonderful group in CDC in Atlanta, but it's nowhere near enough to deal with 1 or 2 outbreaks. What if there are 100, 500? The world hasn't invested in that kind of a system. It's the reinsurance industry, as we talked about earlier, that ultimately bears the cost. It's us as taxpayers and governments that bear the cost of our inability to maintain this kind of a structure. And WHO, and I worked for WHO for 10 years, and everybody who worked for WHO for 10 years has a love-hate relationship with WHO. That's hardly a secret. And WHO was late, and it was slow, and it was inadequate in its response. U.S. government was forceful and strong, but late in our response. Every place you look at, you will find mistakes that were made. Tony was famous for getting on television and calling a spade and saying, we've made mistakes. We should understand that that happens, but it gets magnified in a case where all the things exist as Tony described, that it's a perfect storm. I think the lesson that we have to take away from it is that the pandemic will not be televised. It will not occur at a place that was convenient for us or a time of our choosing. And if we want to be prepared for it, we've got to invest the training, the people, the money, the infrastructure. We've got to create the governance and the institutions. Just like after the Second World War, when the nations came together, we do not want a war again. We don't want a world war again. And we're going to create the institutions that are circuit breakers and buffers. We need to have something that dramatic.
But is the will there? Are the resources there to do that, NEERAJ?
So I think part of the lessons and related to resources is we didn't learn from our previous lessons learned. And so we had SARS and we had other diseases, and there was a lot of analysis done and lessons learned from that, but we didn't bring this to the next epidemic. And every time there's an outbreak or an epidemic, it feels like we're digging the well when the fire's on. But the international community has rallied together with leadership from the World Health Organization in the creation of the IHR, the International Health Regulations, which initially was started off to respond to things like smallpox, dengue, and cholera. They've now expanded it to include all diseases, any form of outbreak, including natural disasters. And all the countries have actually signed up to this. In addition to that, the United States, with a few other countries, has set up the Global Health Security GHSA agenda. And that's actually saying, how do we rally around this? Countries like Argentina, for example, have actually proposed this whole notion of white helmets. How do we go in and respond in these sorts of situations? One of the biggest things that most countries have as a resource in terms of mobilizing people to support this, and we saw this in Ebola, is their armies, the armed forces. And so it's that whole notion. So we're starting to see political will and commitment and how we allocate resources to respond to these epidemics. The next time something happens, we'll see how that actually works.
Well, are we prepared for the next time?
No, I mean, we get better every year. I mean, I'll give you an example of that. I was part of the group that made a movie called Contagion. I don't know how many of you saw that, but we made that movie on purpose because H1N1, which was a highly infectious disease, probably infected more people quicker than any other disease you could imagine, but didn't have a high mortality rate. The response from the community was, well, you hyped it too much. The epidemiologists exaggerated it. We wanted to show what a real pandemic would look like and to try to, in an honest way with good science, show what happens to the deterioration of civil society, the economic costs, the other costs. And we showed that movie to Tea Party activists, Republicans, Democrats. We showed it in the House. We showed it in the CIA. And I had one wonderful conversation with a Tea Party activist who said, I was telling everyone in my community, we must cut the budget, cut everything, no exceptions. Don't make an exceptions of defense, don't make any exception. And then I saw the movie Contagion, and I saw what a pandemic would look like. And now I say, cut everything except pandemic preparedness. and I think if Ebola has that same effect for a little while, if we can use this moment, if there's a silver lining in this awful cloud of Ebola, maybe it will be that we'll have an opportunity to really be serious, to really allocate the resources we have to build and help countries that don't have the infrastructure.
STORN, did I understand you to say you think there is support, sufficient support in Malawi today, in your country, to be ready for,
Yes,
to do everything possible to prevent the next outbreak?
Yes, I think the will is there at every level, but what we've learned from this problem is to get our priorities right. Because in the past, we used to say that problem is not there, then you find that you don't put the resources there. We don't have all the resources in the world. In our countries, the resources are very limited. But someone was saying it's just a matter of getting your priorities right. So this is time we have to start thinking of things that can come suddenly in the future and get prepared, including simple things like protection for our health workers. You know, the Ebola problem came with it that it was killing us as health workers. So you need to make sure that you protect both the health worker and the patient, so that if you don't put that in the preparation, you find that you have a disease there, you have nothing to work with, no protective wear, no infrastructure. So with the little we have, I think let's just get our priorities right. Let's not forget the things that are yet to come.
So I think there may be an opportunity where we don't have to wait for the next big epidemic or killer to come. And it's one thing to have political commitment by countries signing a paper, but then actually saying, how do we make this happen? And that's looking at diseases like dengue fever and chikungunya. And these are diseases that don't have high mortality, but have very significant morbidity. It is paralyzing for when people are going through this fever. And it's spreading like wildfire. It's spreading to the southern parts of the United States. It's been in the Caribbean. It's been in parts of Asia. And as Tony will say, we have a vaccine for it as well. So if we have the vaccine, we have a simulation scenario of a disease that could be spreading like how a pandemic could spread. It requires the same type of infrastructural response as we would require for a pandemic. Well, this is our opportunity to actually test run or prototype our response.
So, and what about that, Tony? I mean, and I was going to turn to vaccines and where we are, because we all know that there's an issue around pharmaceutical companies being willing to manufacture vaccines.
So vaccines are a very complicated issue. We have extraordinarily effective vaccines for certain infections that I've mentioned before, the eradication of smallpox, the elimination of polio, the complete suppression of measles. But we also have situations where we have vaccines that we know we can develop for diseases like chikungunya, but there is not the will, both from the pharmaceutical companies and even from some certain countries, to make the investments to take that concept development to a product. So at the NIH, our people at our Vaccine Research Center have a chikungunya vaccine that looks really good. Good immunogenicity, good safety, we're ready to go. We are struggling to find a partner who'll make that investment to help develop it with us. And then you have the other issue with the vaccine.
Why?
Well, because it's not a big money out. I mean, when there are a handful of pharmaceutical companies whose major concern is the public health and lesser a concern. But most of the time, understandably so, Judy, that the direction a pharmaceutical company will go is, in a great sense, driven by their shareholders. Right. And if a pharmaceutical company is going to say, I'm going to make a product, and the product ranges from the time you make the concept to you have it on the shelf, anywhere from $700 million to $1 billion. So if you're going to make that investment, you want to go for a blockbuster. So if a company has the option of making a new lipid-lowering agent or a better Viagra or a Viagra for women or an antihypertensive that millions and millions and millions of people will use every day, you can bet they're going to go with that, as opposed to something that almost by its nature is not going to be very expensive, because the people who are going to need it the most are the people who can't afford it.
So is there another model for getting these vaccines made?
Well,
that
the government
prevent...
is trying, but we're not the full solution. Is that if you look at the spectrum between developing of a concept and making a product, there's been this partnership throughout the decades between the pharmaceutical companies and the government, which supports academic people to do the science, that we do the initial concept, maybe the phase 1 trial, but the company goes all the way here and takes the ball of putting the major investment. If they're not going to do that, the government makes more and more investment in trying to do what we call de-risk it for the company. Take the risk out of it to get the product almost to the point of essentially making it, and then they'll come in and do it. A lot of that was done with the Ebola vaccine. The Ebola vaccine was developed at the NIH by NIH scientists. And thank goodness we had GlaxoSmithKline to come in and partner with us to essentially produce it.
We have just a couple of minutes before we want to take questions from you, if you have them in the audience, and I'm sure many of you do. But Larry, to what extent are vaccines an issue for the kinds of potential infectious diseases, pandemic sources that you were talking about earlier? I mean, that's not really the issue, is it?
I don't think there's ever been a vaccine for which there haven't been a group of people who are anti that vaccine. And sometimes the reasons, while not scientific, and we would say perhaps not rational, are really good reasons. In India, there was tremendous resistance to the smallpox vaccination because it was created by killing cows. What were we thinking? In much of the Muslim world, the rumors get started that the polio vaccine is an instrument to sterilize Muslim men. That sounds far-fetched to us, but our CIA did embark on a fake vaccination drive in Pakistan. And even in the case of
Osama bin Laden.
trying to get Osama bin Laden, and even in the case of our routine childhood vaccinations, it was one of our publications, our community's publications that we respect, Lancet, which allowed the publication of a fraudulent article, fraudulently leaking autism to vaccines. And then the way in which it was withdrawn raised suspicion. We've not done enough to understand the cultural and individual, moral, psychological objections to vaccine. Because the vaccines that we're talking about are the best things that have ever happened in medicine. They've reduced mortality rates, childhood mortality rates, from 30, 40, 50% down to 4, 5, 6% in the world. We should be so proud of them that we should be willing to hear the objections that people have culturally and meet them halfway, because my community, the scientific community,
Right.
hasn't done as good a job as we should listening.
There certainly still are strong voices out there raising questions about it. NEERAJ, were you going to weigh in on the vaccine?
So the competency of the medical and scientific sector is to actually develop these vaccines. But in terms of uptake at the community level, this is where we need an interdisciplinary response. We have to have sociologists, anthropologists who understand local cultural practices. And this can happen through partnerships. And a simple example, when I was in a community telling people the importance of washing their hands to prevent disease transmission and the germs and oral-fecal contact, they didn't listen to me. When I brought in the church, who said cleanliness is next to godliness, all of a sudden people wash their hands. So messaging and marketing of these strategies are very, very important.
All right, we want to go to questions in the audience, and I believe there's a microphone. We already have a question right here on the third row. We're going to bring the microphone to you.
Thanks for this great panel. So I know, at least in the media and popular perception, has really pushed a lot of anxiety around developing an Ebola vaccine as fast as humanly possible, and the fact that there's almost these crash vaccine research programs that took place to find viable Ebola candidates, vaccine candidates. Yet we know that a vaccine for HIV, a vaccine for malaria, and a vaccine for TB don't exist yet, or at least not very good ones. And so I guess I want to find out a little bit from you, in terms of the three biggest public health killers, particularly in sub-Saharan Africa, why is it that we don't have a vaccine yet when this is what's killing more people than Ebola is? And should we be focusing our efforts on finding that Ebola vaccine when maybe our efforts should be focused on what's killing the most people?
May I ask, do you come from the healthcare community, or you?
Yeah, I work for PATH in Zambia on malaria.
So let me start off. That's a great question. So in vaccinology, in the field of vaccinology, what you learn from the very beginning is the best way to make a vaccine is to mimic natural infection with your vaccine without hurting the person. So when you have diseases, as difficult as they may be with morbidity and mortality, that ultimately get cleared by the body's immune system, that's a surefire hint that you're going to be successful in getting a vaccine. Smallpox kills a certain percentage, depending upon where you are, 15 or 20% of people, but the rest of them recover and develop an immune system, immune response that protects them from challenge. Measles, the same thing. You get measles once, you're good to go. You're not going to get measles again. The same thing with polio. Most of the people recover from polio. So the proof of concept is that you can do something with the immune system. Now, take HIV. The one thing you don't want to do is mimic the immune system's response to HIV, because the immune system does not handle HIV very well. Nobody of the 70+ million people who've been infected have spontaneously cleared the virus. So the body has a problem in their immune response. Malaria, sure, you make an immune response against malaria, but even if you've gotten malaria once, and if it didn't kill you as an infant, you'll get it again. You may not be as sick, but you'll get it again. Tuberculosis, we still don't fully understand the interdigitation between the immune system and tuberculosis. So those three big killers Unfortunately, it's very, very difficult. Ebola, people recover from Ebola. So you never say never and you never say always in medicine, but I can almost guarantee you that we will have a successful Ebola vaccine, because all we need to do is mimic the body's response against Ebola. And that's really the difference of getting a vaccine or not getting a vaccine. It's the nature of the infection itself.
How long will it take to get that successful Ebola vaccine?
Well, I think Judy, we probably already have it, and we just need to prove that it works. I mean, if you look at the relationship between the response it induces in an animal model, it protects animals very well. We know it's safe. We've tried it in the United States. We've tried it in Africa. We just need now to prove that it actually works. The bad news is we're not going to be able to prove it likely because there are no incidents of infection now. The good news is that the infection rate is so low in West Africa that people are not dying in throngs the way they were months ago.
Okay, it's dark in here, so if you raise your hand, you may have to wave it so I can see you. Is there a hand? I'm having a hard, here's a hand right here. And there's another one over there. We'll go to you first, sir.
Thanks so much for a wonderful discussion.
You can tell us who you're with first, if you want.
My name is Brian Eustace. I work with Partners in Health in West Africa. I was encouraged to hear some of the conversation around thinking about sort of attacking some of the root causes, the social determinants of what's happening, and particularly in related to pandemics. And the idea, Dr. Storm, as you mentioned, as frontline healthcare workers and things like that. I wanted to touch upon what you were saying, Dr. Brilliant, around this idea of a sort of a rapid response team and kind of building up this sort of surveillance. I think about sort of the systematic approach to how those things could be used for addressing all types of healthcare issues. And in a place like Malawi, where the MOH healthcare spending might be 40 times less than what the per capita spending should be on folks, how do we actually build those types of resources in communities so that it can exist? Not by chance, no American who was infected with Ebola died. I think it's because we had not necessarily rapid response teams, but strong healthcare systems to address the issues where that doesn't exist in other places. Is it that we have a sort of a global response team, or whether we actually can kind of address those core pieces?
Well, first of all, I want you to know I kept my promise, and I'm wearing my Partners in Health shirt. I just want to make
That's
that very
wonderful.
clear. There's a group called TEFINET. Does everybody know about the EIS program at CDC, the Epidemic Intelligence Service Program? It's a phenomenal training program. It takes physicians mostly, but now in addition to physicians, allied health professionals, and gives them a 2-year part didactic and part experiential program, turns them into epidemiologists. CDC has not only trained hundreds, even thousands of people in that way, but it has also proliferated that system around the world. So there are about 25 countries that have an EIS-like training program. And this community of epidemiologists, as many as 30,000 of them, all belong to another group called TEFINET. I know it's a lot of acronyms, but that's where I would begin. I would begin with these trained epidemiologists that are already placed all over the world, that already have their annual meetings, that already have their electronic communication systems, ProMed, and things like that. And I would build it, I would support it, I would add money to it, I would add clinicians to it, because not all these people are any longer clinicians, and I would add institutions to it. And in fact, we've been doing that at the Skoll Global Threats Fund. We've been funding TEFINET, trying to train epidemiologists in digital disease detection, point-of-care diagnostics, containment, and I think that there's where I would begin. Instead of starting de novo and getting a whole new organization, I start with people who are trained, have chosen that as their profession, who are really eager to go into battle and do battle if we can figure out the economic and infrastructure ways.
Okay. Yeah, I think we had a hand over here. Yeah, a couple of hands. Back there where you are, yes.
I've spent a bit of time in Guinea and Liberia over the last few months, and one of the challenges that I've seen actually is that the response has really been run by doctors entirely. And particularly in Guinea, what happened is that epidemiologists came in, but they didn't have anthropologists and sociologists and people to work with the communities. And then I hear you talking about needing to train more epidemiologists, and it seems like that's kind of what got us into the problem where we are today, where the communities in Guinea don't trust the people that arrive in personal protective equipment. They have their windows rolled up in their cars, they have helicopters, all the things that really scare people. And it seems to me that we need a much broader response, and we don't need a response that is completely run by doctors. We need a whole lot of other people, logisticians and anthropologists and other people. So I guess
I'd like to respond to that.
Sure.
So first of all, the people who were on the ground for the first 6 months were not epidemiologists. That was part of the problem. They didn't recognize the epidemic nature of the disease and how it spread. But I completely agree with you. We were talking about this earlier. It is an absence of anthropologists, culturally sensitive people, people from that community that causes most of the difficulties that you described. You're absolutely right, except for the first part. It wasn't the epidemiologists who were in there doing that part of it. But yeah, I mean, this is an all hands on deck situation, and we make mistakes when we don't listen to all the different parts of our human community.
See, another hand, this gentleman right here.
David Sklar. So I just want to bring up one other issue that we haven't really talked about, which is the issue of the political ramifications of particularly our response in this country to whether it be Ebola, or if we think back about concerns about bioterrorism back after 9/11. And it seemed like a lot of times our response was doing things that were the politically expedient thing. So we've wasted, I think, enormous amounts of money training people so that every hospital might be prepared for the next Ebola case that came along, when in fact there probably was a much better way to structure how we would address those kinds of things. I just wonder if you might want to respond on, it seems like, organizationally we have trouble dealing with things that are sort of politically sensitive infectious disease emergencies.
Don't everyone speak at once.
So the Ebola response, you note, I testified at about 9 congressional hearings before the election, and as soon as the election came, I wasn't testifying before congressional hearings anymore. And there was a lot of interest in that, and we live in a political environment, we do. I mean, there's a lot of good about that, but sometimes that political considerations tend to sway responses, and there are sometimes over responses and sometimes under responses. Larry and all of us have been talking about how you just don't respond to something because it's not on the radar screen. When at the end of the series of several of them, someone asked me about, were we overkilling? And I was trying to make the balance of that. I've testified before Congress more times than I could imagine, and it's very difficult to get somebody excited about something that hasn't happened yet. And it really is. I mean, to testify before the Congress and talk about pandemics, it's sometimes very difficult to get the sustained attention. Yet when something happens, even when it isn't necessarily a threat in the sense of being a real risk, we have trouble communicating the relative risk of something. And I think that maybe relates to what you say. So we as a society are willing to accept risks that are substantial risks because they've been with us forever, we're used to them. Once you insert a new risk in there, society and our political leaders tend to respond to that, not in proportion of what the relative risk is, but because it's a new risk. And even if that new risk isn't anywhere near as difficult as what you've accepted every day, nonetheless, you can overreact to that new risk. And the analogy I always give is, say, the risk of having a big outbreak of Ebola in the United States with our health care system, that's a new risk for the American public. Yet in that room in Washington where I was testifying, that people, most of them, come to work by the Washington, D.C. Beltway every day. And the idea and the possibility of getting killed on the Washington Beltway is infinitely greater than there being an Ebola outbreak. And yet we, every day, go to work and accept the Beltway, but all of a sudden, we're worried about a big outbreak. So you're right in that.
All right, comment, and we've only got about...
I think there may be opportunity to rephrase this whole development investment. And if we look at development traditionally, it's benevolence. It's how do we help people who don't have, build that infrastructure, etc. I think if we have to change the argument to say, it's in our interest to actually deal with this, because we live in a globally connected world. And Ebola came here to our shores. Fortunately, touch wood, it didn't sort of explode, but the next one might. And the way we tackle this is actually going to the source to prevent it from coming here. And we can build on the political leadership from the countries. Malawi's got all these health workers. Ethiopia's got health extension workers, which they're based on the barefoot doctors from China and the ashas in India. And we start building the infrastructure from the origins of these disease, which then protects American lives here and sort of creates this global protection. But we have to change that rhetoric, and that's the way I think we need to start building political will.
Okay, we're out of time, but I'm going to let this young man right here ask a question, and that'll be the last one.
Hi, thank you very much. I am I guess, bacteriology biochemist by a researcher at St. Jude Children's Hospital, and I'm wondering kind of where you see, as a researcher, where are some of maybe the deficiencies that, areas that we could be studying in more depth that could not only help the United States, but some of the more developing countries?
Good question. Where do we need the help?
Well,
what should they be studying?
There's so many things that are fruitful, as you well know. But just take the issue of an emerging infection as one of the many problems we've talked about. One of the things that's really tough to do is to try and chase a new microbe as it comes along and start from scratch. It's kind of, do you have to have a new starting point for every new microbe? So you're going to make a vaccine against every possible microbe or an antibiotic against every possible microbe. One of the things that is the fruitful area of research that I believe is to look at generic platforms where you can start thinking in terms of vaccine platforms that you could plug in whatever insert of a gene of a particular microbe that you have. We now can sequence a microbe in a few hours. You know, it used to take a year. You could do it in a few hours. So when you isolate it, you don't even have to grow the new microbe. You just stick it into your already predetermined vector, if that's your vaccine platform. And the same thing with broadly reactive antivirals. There are so many exciting things that we could do now that's what I would recommend for someone who's in the early stages and wants to look at an impact you could have on infectious diseases.
Okay, that was the last question. Three of you want to add anything?
I would just
hopeful note to.
I would add one thing,
Yeah.
which is I'd look at the virus that we suspect to be the most likely to be causing the kind of pandemics we're worried about, and that's influenza. And we have some superstitions about it. We have so little real information about what makes the roulette wheel of the H and the N turn in the way that they do. It would be wonderful if there was more research attention on that.
On that note, let's thank this amazing panel, Larry, Tony, NEERAJ, and STORN. Thank you. Thank you all.